بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. المرة اللي فاتت احنا عملنا سمري للهايبوكاليميا. And today our approach today to how you can summarize any patient came to emergency or our clinic or as a consult for nephrology or general internal medicine or ICU for hyponatremia, how you can manage my patient or your patient, how you can just fix one clinical approach to in your mind in this topic, hard topic, hyponatremia. I will try today to summarize this approach at the clinical, how you can deal with different hyponatremia cases in your consult or your clinic. أولا نبدأ بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. دايما لازم نبدأ بالصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. السلايد دي طبعا لنا كلنا. You can't improve what you don't understand. This for all of us. You can't improve what you don't understand. You should understand what you are dealing and to at least to end by best management for your patient. Well, the first slide here, how no approach to hyponatremia. Some question you should ask yourself. First, second, third, fourth, fifth. First question: is this true hyponatremia or no? Is this a real hyponatremia or true hyponatremia or no? First, when you consult you as one patient for sodium around 110, 109. or 115 like that, you should repeat first. Please send another sample now stat for repeat serum sodium. And you should rule out pseudo hyponatremia. And then we'll come for this in our approach. Second question, it's really real hyponatremia. Don't forget to ask for serum osmolarity. If no serum osmolarity available in your blood work, you just ask for serum osmolarity. And third question is acute or chronic. Acute, mostly acute cases you will see in our inpatient hospital. Already patient بتنام في المستشفى or patient already admitted in hospital. Or chronic, any hyponatremia came from outside the hospital. If no recent labs, this chronic until proof otherwise. Only just this will rule out the chronic if recent lab within 48 hours. Fourth question, volume status. Our patient is volume contracted or volume depleted or eovolemic or hypervolemic, and we'll come for that according to extra-arterial blood volume status assessment. And fifth question, are they safe? What means by are they safe? When you are consulted for hyponatremia, Dr. X, please, we have one patient, his sodium 110, and this is patient known case of epilepsy and came by seizure and a little bit decreased level of consciousness. Your patient now unsafe. You should deal with this patient as emergency case. Don't wait to approach to diagnose this patient now. We need to stabilize your patient first, stabilize your severe symptoms or complication of hyponatremia, and then you can reach to your diagnosis or what is your cause or etiology for his hyponatremia later. But first you should deal at the emergency with any emergency hyponatremia. Just this diagram, types of hyponatremia we have already. This hypotonic, isotonic, hypertonic. This diagram to show different type after we reach to serum osmolarity. When we see hyponatremia, sodium less than 130 or less than 135, after that you should ask for serum osmolarity, and the serum osmolarity will divide your patient to three, either hypotonic, hyponatremic, hypotonic, hyponatremic, isotonic, hyponatremic, hypertonic, and will come to all this. And the hypotonic, eovolemic, hypervolemic, hypovolemic will come to all this. Hyponatremia or sodium less than 130, for example, and serum osmolarity, second step serum osmolarity. Just put in your mind that hyponatremia, the cause of consult, you will check serum osmolarity, and after that you can divide your patient either isotonic, the patient was proteinemia or paraproteinemia and hyperlipidemia. This pseudo hyponatremia. This is the cause of pseudo hyponatremia. This patient with lipids and proteins. Okay. يعني مختصرين في اللحوم عموما يعني. لو العيان hypertonic or hyperosmolarity this with hyperglycemia، الحاجات اللي فيها تركيزات عاليه، فيها concentration عالي، hyperglycemia، مانيتول، جليسرول، جلايسين، مالتوز، سكروز، دي الحاجات اللي فيها osmotic gradient high. with high osmotic gradient, all patient with high osmotic gradient is hyperosmolar. This is another cause of hyponatremia. I have one patient recently, I am consulted for him for AKI post-cabbage, and I found his blood sugar is around 55 millimole, not 40, 55 millimole. His blood sugar during this attack of acute coronary syndrome, this patient already post coronary angio, and he consulted us for creatinine 400 micromole from his normal around 80 micromole. And I found his sodium 122. I don't mind this 122. I just manage my patient because the patient severe metabolic acidosis and hyperkalemia with AKI. I manage him with bicarb. I'm not looking for sodium because it's correct sodium around 126 like that, or 128. And I treat him, and the second day everything is okay for him, nothing, no overcorrection like that, because he's already pseudo hyponatremia from this osmotic high osmolarity from hyperglycemia. Now, as we mentioned, theorem osmolarity, either isotonic or isotonic or isoosmolality, this patient with lipids and proteins that already in meats or in our foods, and this also hypertonic hyperosmolarity. This is either hyperglycemia and mannitol, glycerol, glycine, maltose, sucrose. Hypertonic, this patient hypotonic hyposmolality, and will divide this patient hypotonic hyponatremia. If this hypotonic hyponatremia is acute less than 48 hours, I will treat with 3% normal saline. Hypotonic hyponatremia acute less than 48 hours should treat with hypertonic saline. If this chronic, will check urine osmolality. Urine osmolality already the patient more than 100, this patient either hypovolemia or hypervolemia or euvolemia. Of less than 100 urine osmolality with psychogenic polydipsia. The other urine osmolality more than 100 and all this hypovolemia and hypervolemia and euvolemia. We'll check here hypovolemia, and will come this treat with IV fluid and monitor this patient high risk for osmotic demyelination syndrome. This patient was hypovolemia. You will find urine sodium less than 20, or less, this is vomiting, diarrhea, burn. Is this patient with fluid loss already, or more than 20 milli equivalent with diuretic, adrenal insufficiency, renal salt hosting, cerebral salt hosting will come to that. And this patient need treat with IV fluid, but be careful to keep DDVB beside your patient. DDVB and diuretic hormone, this just to avoid more overcorrection and osmotic demyelination syndrome. And I already presented this osmotic demyelination syndrome in separate presentation because it's handicapped complication already for hyponatremia for our patient. Hypervolemia, just don't forget this three major causes: congestive heart failure and liver cirrhosis and nephrotic syndrome. Just we'll come to this also in our management. Euvolemia, this sodium more than this more than 20. Just we need to rule out this hypothyroidism and adrenal insufficiency and the drugs like diuretic, thiazide, and Cyad also in our differential diagnosis of euvolemia and non-steroidal intake. This other diagram from Twitter, this is hypoosmolar hyponatremia. As we mentioned before, either hypovolemia, and we divided here euvolemia, included the primary polydipsia, and the patient with SIDH, and the butomania already will come to that, and the hypovolemia is congestive heart failure, cirrhosis, nephrotic syndrome, and we'll come to that in details. This from Harrison, this is just a nice simple classification, either true hypovolemia. If your patient, you examine your patient hyponatremia in the consult, and my examinations is patient hypovolemia. Is the skin overbone and the patient dry tongue, everything sign of dehydration already with him. GVB not raised, the chest is clear, no signs of edema or overload. Just this true hypovolemia, either from GI loss or renal loss. Eupholemia, either elevated antidiuretic hormone like SIADH syndrome, inappropriate antidiuretic hormone secretion. Just you will think when I am thinking in this SIADH in CNS lesion, especially any consult from neurosurgery after any brain surgery, or any from oncology also. Oncology and neurosurgery, you should think in this eupholemia SIADH, either from CNS lesion, tumor, whatever, or metastasis, or malignancy, or drugs intake also can cause sciatica. These are the most common causes. Don't forget thiazide diuretic also. With other regard, hypovolemia, eupholemia, and this will come to this hypervolemia, congestive heart failure, and cirrhosis, and will summarize all. This is the most common consult here. If through hypovolemia, GIT loss, whatever, this can be treated by normal saline, but take care, this patient maybe will go overcorrected. You should put a DDVB beside your patient to avoid overcorrection and osmotic demyelination syndrome. This is the most important one for this high risk already. Eupholemia like SIADH, CNS lesion, and malignancies, all this can lead to this. Hypervolemia, congestive heart failure, and liver cirrhosis, and we'll come to that already. This is the main three: hypovolemic, hypervolemic, eupholemic patient. Hypertonic delusional hyponatremia, as we mentioned before, this is hyperosmolar, either from hyperglycemia. Each sodium will decrease by 1.6 for each 100 milligram glucose above 200 milligram per deciliter. This just a simple calculation for your patient if you have milligram per deciliter. And also second differential diagnosis for hypertonic or hyperosmolarity is mannitol or IV intravenous immunoglobulin, glycerol, glycine, and maltose sucrose. Pseudo hyponatremia, as we mentioned, hyperlipidemia and hyperproteinemia. This from meats already, lipid in the meats and the protein in meats. This is the meat diet, like in multiple myeloma, hyperproteinemia like multiple myeloma. Don't forget that. You know, any patient with an iron gap below or zero, then you should think in the multiple myeloma. And just a treatment here, nothing, just treat the cause, okay? What is the benefit of urine electrolyte or urine osmolarity or urine sodium and the potassium like that? This will help to guide you in euvolemia, hypervolemia, and hypervolemia. And we'll see now this hypovolemia. What is your sodium and the potassium in a patient with hypovolemia will be low, less than 20. Okay, less than 20 sodium or potassium and high urine osmolarity. This patient with hypovolemia. Hypervolemia also may be, you will find urine sodium potassium low because intravascular volume depletion, and urine osmolarity is high because all fluid insert space already. Subcutaneous extracellular. Eupholemia, the patient may be normal or high, you will find normal, but the most important, you will find high urine osmolarity, especially in SIADH patient. What is the acute management? This the first message for you or summary for our presentation before for hyponatremia, acute management. When I see one ER doctor, emergency doctor, call you, Dr. X, please, we have one patient severe hyponatremia and emerge. I need your help because they are a nephrologist, and I know nephrologists that have a wise management for any patient with hyponatremia. I need your help in management this patient in hyponatremia. You should put this in your mind. Don't forget when you are going to emerge to see this patient or any critical patient with hyponatremia, just put this in your mind. If this patient less than 48 hours, acute hyponatremia, we have risk of, if a patient prolonged for that, we'll have risk for herniation. Herniation will come from where? Because intravascular sodium will be low, but inside the brain cells, sodium is high. So our blood or intravascular is hypotonic, but the brain hypertonic. The brain will take more fluid and lead to brain or cerebral edema and herniation. Okay, osmotic demyelination syndrome. If your patient is chronic and hyponatremia, take care from that. Why? My brain now is hyponatremic. Okay, your brain is hypotonic and intravascular hypotonic. Okay, I will correct the sodium. Sodium will be intravascular. Intravascular now will be hypertonic, and the brain is still hypotonic. I discussed this already in details in our presentation before on osmotic demyelination syndrome. If the brain hypotonic and I might correct the sodium rapidly and the intravascular now hypertonic, this will take fluid from the brain and lead to shrinking already our brain and lead to osmotic demyelination syndrome, as we discussed before. Take care from this 2 point when you are going to clear. My patient less than 48 hours, more than 48 hours, and I will tell you now how you can be wise in management this patient. And there's the danger of our chronic hyponatremia, because the rapid increase in sodium will make intravascular hypertonic and inside the brain cell hypotonic, because we need time, maybe 1 day or 2 days or 3 days to make equilibrium between intravascular and intracellular inside the brain cells. If you rapid correct your sodium, and the intravascular will be hypertonic, and the intracellular inside the brain cell hypotonic, will take more fluid from the brain to intravascular, and the brain will be shrinking and demyelinated. Management of hyponatremia. This is the most, just I need you to keep this approach. I will send this copy for you. I will take this picture for you also, and I will send in the group. Management of hyponatremia, plasma sodium less than 130. This is adapted from Kamel Halper in 2017, and the other already. And severe, as regards the symptoms, we have severe symptoms. What means by severe symptoms? Patient seizure, coma, patient with ARDS, all these symptoms, and decreased level of consciousness, confusion, agitation, like that. All these severe symptoms. If yes, I will go to emergency. Emergency here, I will give hypertonic saline. Our aim to rise the sodium 5 millimole. If it's 1010, I need 1015. If it's 1015, I need 1020, like that, in the first 24 hours. But you should raise this 5 millimole at least in the first hour. If the patient symptoms is still not improved, I will go another 5 millimole. Just now, but the maximum 8 to 10, and some box now just maximum 6 millimole every first 24 hours. Did the most already done by ICU's doctor in neurosurgery ICU, and found this 6 millimole. That's enough to keep the equilibrium inside your brain, intracranial pressure. And we have two protocols, either European or American one. Just give bolus 100 ml. Will come here. This European one 150, American 100. American 100 here will give 3% hypertonic saline 100 cc ml, 100 ml over 10 minutes, and you can repeat this for 3 times. This is the American approach. European 150 ml over 10 minutes, we can repeat twice also. But already we can give 300 over 60 minutes, and will come. I will give you a equation for that to be easy for you. Just if you are away from hospital and the ER doctor call you, you can ask him to give 100 hypertonic saline if the patient symptomatic, or 150, and if the patient still symptomatic, you can repeat another one until you arrive to assess your patient. This is the most safest for your patient. If the symptoms improve, yes, therapy, and check the cause now. Just know the patient is stable now. Just try to search in the cause by your examination and your workup for hyponatremia. If the symptoms do not improve, just give another. You can continue 3% normal saline, 1 cc per kg per hour, until increasing the sodium around 10 millimole, or symptoms improve, but the maximum don't increase more than 10 millimole per day. Or if you are sure this acute hyponatremia, at least don't pass this 130 if it's acute hyponatremia. This, as regard with patient with severe symptoms, I can deal by this, and I will give you another equation for another to be safest approach, as by Dr. Kamel and Halperin. I will come in the next slides. We have now, you can give 200, 100, 150, and 300 over 60 minutes. This all over 10 minutes. I can give this over 1 hour, and we'll come to this now. Or we can give hypertonic saline 2 cc per kg over 60 minutes. This is already by Dr. Kamel, but I will explain for you how this 2 cc per kg over 60 minutes, over 1 hour, will 2 ml per kg. If my patient 60, I need to give to 120, I can give this 60 ml over 30 minutes, or can give already all this over 60 minutes or over 30 minutes if the patient is in severe symptoms already. If the patient without coma or seizure, we are this moderate symptoms like headache, nausea, vomiting, confusion, Yes or no? If the patient with moderate symptom, the headache, nausea, vomiting, confusion. If yes, with acute hyponatremia, and the patient, especially if the patient with any brain surgery or pathology or tumor like that, I should go to emergency management like this by hypertonic saline. If not acute hyponatremia or brain pathology, just I will give 3%, aim to increase just 5 millimole over in 6 or 12 hours, or give 3% normal saline 100 cc over 20 just once, or you can give 15 to 20 ml per hour for 5 hours or 6 hours and repeat sodium later, but put in your mind, don't increase more than 5 millimole per day, or 3% saline 3% 1 ml per kg per hour for 4 to 6 hours, whatever approach you like. I give you multiple approach here. Anyone come in your mind, just manage your patient in emergency and be safe. And they will put in your mind, don't increase more than 5 millimole, except if a patient with seizure like that, you can reach up to 6 to 8, and we'll come to all this in the next slide. If my patient with no symptoms, no headache, no nausea, no vomiting, no confusion, and if it's no, if you are sure this patient with acute hyponatremia, if yes, I will give these protocols again, aim to increase 5 millimole over 12 hours. If no, no definite acute hyponatremia, just treat the cause. If your patient not with these symptoms, avoid how to can avoid any overcorrection of hyponatremia. If the plasma sodium less than 20, yes, risk factor for osmotic demyelination syndrome. You know, risk factor for osmotic demyelination syndrome: hypokalemia, severe hypokalemia, malnutrition, cirrhosis, alcoholism, severe hyponatremia less than 110. Is the risk factor for osmotic demyelination syndrome, and we discussed already in the previous presentation in osmotic demyelination syndrome. And I think I put 2 videos for this, or 2 presentation for osmotic demyelination, because it's risky, and the bad thing you will face in your life in management of hyponatremia. Hyponatremia is not simple topic and not simple consult. Hyponatremia not easy consult here. Risk factor for osmotic demyelination syndrome: if yes, I will give proactive DDVB. What means by proactive DDVB? I will give DDVB to protect my patient from overcorrection. If I will give him hypertonic saline by infusion or boluses, I should look my patient by DDVB either 2 to 4 mic, IV, or sub-Q every 6 to 8 hours. Every 6 to 8, this will protect your patient from overcorrection. If you will correct my patient more sodium 110, and they give him hypertonic saline, maybe you will go to 114, 13, slowly correction, better than from 110 to 120, and the patient will go to osmotic demyelination syndrome, and I make my patient handicapped already. Take care from this proactive DDVB. Hyponatremia not easy, especially in patient with high risk. Take care from hypokalemia, malnutrition, cirrhosis, alcoholism, severe hyponatremia less than 110. Welcome now. If no risk factor, likely to have rapid excretion of free water in urine in response to therapy. If you think your patient hypovolemia, and you will give him fluid, and there will be more polyuria. If yes, I will give. I suspect my patient will go to polyuria, like any brain surgery like that, or any severe hypovolemia, and you give your patient will start to be diuresis. This patient you should give proactive before overcorrection will be happen. Or if no, I will give reactive. Reactive, what means by reactive? I give DDVB if I saw my urine output increase 200 ml per hour for 2 hours. After that, after 2 hours, if my patient bringing 400 ml urine, I will give DDVB either 2 to 4 mic every 6 or 8 hours to avoid overcorrection for this. If no, no risk for osmotic demyelination syndrome is very low. If the risk is very low, I will go now to our correction, and we'll see now. Our protocols, as mentioned, just put this in your mind: European protocol, American protocol, hypertonic saline 3% saline 150 ml over 20 minutes. We can repeat this 2 to 3 times and measure serum sodium after each bolus. American 3% hypertonic saline 100 ml over 10 minutes, multiply by 3 times. You can give him for 3 times and measure plasma sodium in betweens. Giving hypertonic saline. This is our equation from our professor, Dr. Kamel. Here, just giving hypertonic saline according to total body water. Total body water, 50% of body weight, 50% of our body weight by kilograms. Volume of amount of your 3% normal hypertonic saline, desired plasma sodium multiplied by total body water multiplied by 2. He simplifies this also to this equation, desired plasma sodium multiplied by total body weight. Okay. But desired a rise in your plasma sodium. And what means by desired rise in plasma sodium? This means if I need to increase my plasma sodium from 110 to 115, this is desired how much now? 5. I need 5 to increase my patient 5 now. I multiply this 5 by body weight. Okay. And will give you amount or volume. I will give over 1 hour to 2/3 of the total in the first 30 minutes. I will give 2/3 and then over 30 minutes. Okay, this already by Dr. Kamel. And for example, we'll give you an example to be easy, 60 kilograms multiplied by my desired increase in my sodium 5. This will give you 300 already. And this achieved by giving 300 of 3% hypertonic saline over 1 hour. Over 1 hour, 2/3 of the total in the first 30 minutes. Okay, I think this is an easy question you can give. And we have many approach already. I have another approach with elderly man before. He just giving 50 ml per hour for 4 hours. Or 40 ml per hour for 6 hours, hypertonic saline. But now I'm dealing with emergency patient. If the patient just I give him empirical target weight 60 kilograms multiplied by 5, and they will give this 2/3 of this amount over in 30 minutes, and the other will continue to the remaining hour. And that's okay. And we'll check my serum sodium and urine output. If the patient overcorrected, I will look direct by DDVB. Avoid overcorrection. How? By monitoring plasma sodium, urine lysis and urine osmolarity, and urine output. Urine lysis and urine osmolarity and urine output. The frequent monitoring may be every 4 to 6 hours. I will not say 2. 2 maybe will be done in professional ICU, but from 4 to 6 hours, I need to check plasma sodium, serum sodium, urine lysis, and osmolarity for hypotonic urine or no, and urine output. If urine output increase more than 200 ml per hour for 2 hours, I need to look my patient by the DVB. Otherwise, your patient will be overcorrected and will end by osmotic demyelination syndrome. Please don't, any severe hyponatremia, keep the DVB beside your patient before you start your management, or let the nurse to keep for mic at least beside your patient. If the patient overcorrected or urine output increased more than 200 ml per hour, your patient needs folic acid. You should insert folic acid for your patient. DDVB for McDiana, and consider proactive. The patient with proactive DDVB, what means? I will give DDVB before overcorrection happen. At higher risk patients, especially osmotic demyelination syndrome, malnutrition, cirrhosis, hypokalemia, alcoholism, especially if severe hyponatremia, also especially if the patient not in ICU. If you're afraid the patient in ward and you're afraid this patient will be overcorrected, please keep proactive DDVB. Proactive, what means? I will ask, I will put an order, and I will put like that. Please keep DDVB for mic to be given IV or subcutaneous every 8 hours. If urine output increase to 100 ml per hour for 2 hours, or serum sodium increase above my target, above 5 millimole in the first 24 hours, or above maximum 6 or 8 millimole. Don't be limited. But if your sodium shot up like that and the patient risk of osmotic demyelination syndrome, please keep proactive DDVB in the hand of nurse if any complication will be happening. In almost all cases, avoid correction of hyponatremia faster than 8 to 10 millimole per day. That's maximum 8. Don't be rapid. Why you are hurried to correct the hyponatremia? If this chronic hyponatremia, why you are hurried? Don't be hurried to correct the hyponatremia to reach your target 1/3 or above. Why I am hurried? Just take 2-3 days to correct this. No problem. Better if the patient develops osmotic demyelination syndrome, as I discussed in details before in my presentation, will patient will be handicapped and will be medically ill for you. Okay. If the patient was high risk with osmotic demyelination syndrome, just if the patient high risk, 6 millimole per day, that's enough. Okay. And avoid exceeding 8 millimole per day, maximum 8 millimole per day. Don't increase more than in the first 24 hours. Continue slow rate of correction until plasma sodium reach 130 millimole per liter. I think the message clear. The patient was hyperacute hyponatremia, less than 12 or 24 hours, like the patient taking a study and marathon run or absorption irrigant on operation room may allow correction faster than if this patient hyperacute. Just we can correct 8 to 10 millimole per day, but no advantage to doing so. Yeah, and if you correct more than this, what is the benefit? Just 10 millimole, 8 millimole. If this hyperacute, no problem. Don't reach you to, for example, 125. I will make this to 130, 135. That's okay. Of 120, I can reach 130, no problem. But don't make him from 120 to 140. What is the benefit? Yeah, maybe you will get adverse effect for your patient. And this marathon runner, just this is a common consult also, just came for you. Exercise-induced hyponatremia. This exercise-induced hyponatremia already in serious condition in marathon runner. Antidiuretic hormone level are increased despite hyponatremia. Water consumption during the marathon running. He drink water more than 3 liters. And body mass index is small already. Excess loss of sweat already with salt. And taking some non-steroidal also, this also will increase the secretion of antidiuretic hormone. Running times more than 4 hours post-marathon, weight gain already. This also will precipitate hyponatremia. Treatment, rapid correction indicated in exercise-induced hyponatremia by hypertonic saline. When approach for assessment and management of exercise-associated hyponatremia, heat exhaustion or heat stroke from journal Wilderness or Environmental Medicine 2019. I will send also this copy for you, don't worry. Just will treat as the same diagram before. If my patient came by confusion here, my patient called already by emergency doctor, patient came after marathon running, confused, altered the sensoria, vomiting, seizure, coma, dyspnea, ataxia, collapse. If all this already present my patient, I will go direct to hypertonic solution already. Whatever approach you like from the previous approach, you just manage your patient. And you can differentiate also from other causes, heat stroke, like that, confirmation. That will give him just also cooling fluid, IV saline, like that, will give this if my patient heat stroke, not severe exercise-induced hyponatremia. If my patient weakness, dizziness, nausea, vomiting, muscle, all this we can just I need you from all this summary. I will send all this for you because this will take time also. Just if my patient came symptomatic after marathon running by severe symptoms or whatever, you can give hypertonic saline, stabilize your patient, cooling your patient, and after that give no hypertonic saline. And just the patient already acute hyponatremia. Just treatment, you can just I think 10 millimole per day, that's enough, because I'm sure that patient will not go to severe hyponatremia less than 120 like that. If reach 130, that's okay. Chronic hyponatremia, that's what I need to inform you. How can I manage patient with chronic hyponatremia? Patient came from home, elderly patient, and already I checked his lab previously already. His maximum sodium 122, 124. And maybe 118, 119 like that. How can I deal with this patient? We finish already like acute hyponatremia and how we can manage patient symptomatic acute hyponatremia. If patient now chronic hyponatremia, we are consulted already to solve his problem now for our patient problem, chronic hyponatremia. I will go to my patient, I will examine his extra arterial blood volume. if it's low or high, extra arterial blood volume, this just to check your patient hypovolemic or hypervolemic. Okay, if yes, if extra arterial blood volume is low, if yes, we'll check the extracellular fluid volume. My patient expanded or no. If extra arterial blood volume low, we'll go to extracellular fluid volume. Okay, if it's yes, my patient already edematous like that, generalized edema, as we discussed already before in hypertonic, hypervolemic hyponatremia. We discussed this in details before in separate presentation in congestive heart failure, liver cirrhosis, nephrotic syndrome, whatever. Okay, we'll go with this and we'll treat the cause. You'll treat the hyponatremia. If the patient, if extraarterial blood volume is low and extracellular blood volume not expanded, that means the patient clear primary adrenal insufficiency, clear hypovolemia, diuretic and low salt intake, patient with severe diarrhea, cerebral insult, all this need normal saline and fludrocortisone or cortisone. Okay, this easy now. This is the first step in chronic hyponatremia. Extraarterial blood volume, my patient from blood pressure, GVB, chest exam, skin, lower limb edema like that, any edema, any signs of edema. If yes, patient, my patient edematous, this means congestive heart failure, liver cirrhosis, and nephrotic syndrome. If my patient extraarterial blood volume is low, GVB is flat, and the abdomen, dry tongue, and the chest is clear, lower limb edema, and no, by my patient not volume overloaded, not extracellular fluid expanded, with my patient maybe adrenal insufficiency, by criteria of adrenal syndrome, or diuretic low salt wasting, diarrhea, cerebral and salt wasting also. Continue. Chronic hyponatremia. If we finish this now, if yes. If no, if my patient extraarterial blood volume is not low, yeah, my patient euvolemic or hypervolemic, whatever. Okay, euvolemic. My patient now euvolemic, not hypovolemic. Okay. If the extraarterial blood volume obviously low, if no, this you should rule out thiazide diuretic. My patient on thiazide diuretic or very low GFR. Your patient on that, you diagnose now your hyponatremia. If no, I will check urine osmolarity. If the urine osmolarity less than plasma osmolarity, if yes, my diagnosis now will come now to this patient maybe with polyuria, and will come to this now. If no, if the urine osmolarity not less than plasma osmolarity, if no, if urine sodium and or urine chloride less than 30 millimole per liter, or other labs suggest low extraarterial blood volume. If no, we'll go to a glucocorticoid deficiency hypothyroidism. If yes, this secondary adrenal insufficiency or severe hypothyroidism. If no, this patient might be already SIDH or activation mutation on V2 receptors. Okay, just we'll go now. Extraarterial blood volume low is no. My patient on thiazide diuretic or low GFR patient CKD, if we can diagnose your chronic hyponatremia because the kidney tubules can't control that. If no thiazide or very low GFR already, we'll go to urine osmolarity and plasma osmolarity. If urine osmolarity less than plasma osmolarity, what means by that? If this means the patient may be maybe patient with polyuria, whatever, drinking more water like that, polytepsia like that. If this no, we'll go to urine sodium and urine chloride. If less than 30 millimole, this diagnose your patient with urine sodium low and urine chloride low, means this patient volume depleted already and need normal saline, and already you diagnose your patient with intravascular volume depletion. If no, I will go to check the cortisol and TSH. If my patient yes already with one of them, maybe adrenal, maybe hypothyroidism. If no cortisol, no adrenal, no hypothyroidism, this means my patient is SIDH. This diagnosis of exclusion and this criteria for SIDH syndrome with inappropriate and diuretic hormone. they should rule out hypothyroidism, and adrenal insufficiency should be ruled out. Plasma osmolarity will be low, and urine osmolarity should be high. Urine osmolarity in SIDH should be high because antidiuretic hormone. This antidiuretic hormone will retain the water inside your body and will decrease the urine output, lead to high urine osmolarity. If otherwise no, negative as well, our diagram before, urine osmolarity not urine osmolarity is high here already, and the plasma osmolarity is low. You should diagnose this as SIDH. Euvolemic volume status, when you examine your patient, the patient not hypervolemic, not hypovolemic. My patient blood pressure is okay, GVB not elevated, but already around 3 to 4 above the sternal angle, chest is clear, lower limb edema, but also no signs of dehydration. Elevated urinary sodium also maybe will be high, sometimes will be normal. Okay, and this is the most criteria. What I need to remember, you just rule out adrenal and hypothyroidism. Urine osmolarity will be high, and urine sodium sometimes will be high, and urine serum osmolarity will be low. What is the most common causes? Anything can do some pain for your patient. Any patient under pain, nausea, pain, and anxiety. Drugs like antipsychotic drugs, selective serotonin reuptake inhibitors, malignancy, small lung carcinoma, or any malignancy, pulmonary disease, whatever, even chest infection, CNS disorder, or even infection, administration of DDVB, the iatrogenic, and another radiopathic ADH. And I summarize here for you the most common medication. Carbamazepine can do hyponatremia, selective serotonin reuptake inhibitors, amitriptyline, morphine, all this can do hyponatremia as the drugs. Malignancy, common one, small cell lung cancer is the most common, brain meningitis, subarachnoid hemorrhage, infection, pneumonia, lung abscess, brain abscess, and hypothyroidism. Also, all this can lead to SIDH. In a patient you suspect SIDH, how you can manage this patient? Patient after surgery, pain, especially orthopedic or neurosurgery or general surgery, whatever, just a free water restriction, please. Free water, not all water. Don't put restricted fluid. This wrong word. Just restrict the free water. Don't restrict soup. Don't restrict juice. Don't restrict like that. We need just only free water restriction around 8 ml. Some patient small, you can give about 500 ml. Some patient large, just 8 ml, 700, 600, whatever. High protein and salt diet. If no congestive heart failure or hypertension history, high protein and salt diet. This increase free water excretion also. To decrease the concentration of sodium and potassium in urine, you can use loop diuretic, increase salt intake. You can use also loop diuretic and increase salt intake. Sodium chloride tab. If my free water restriction and high protein salt diet not working well, even low diuretic not working well, sometimes I can use this sodium chloride tab, 1 to 2 gram per oral TID. I will start by 1 gram TID, and urea tab 10 to 30 gram BID, and you can increase it to TID. If that's the goal, this will do osmotic diuresis, will take more water and will elevate your plasma sodium. And just please, when you are doing all this, take care to check your urine. As I told you, urine output per hour. If your patient can't collect, please folic acid for this patient until his sodium will be in safe side above 125. After that, you will be okay. Just 24 hours. If the urine increase more than 200 ml per hour for 2 hours, or serum sodium increase above your target, please just give the DVB. Treatment of poor solute intake. Some patient bear potomania or tea toast syndrome. Some patient can just only taking tea and toast all the day and beer all the day without any proteins, without any diets. Please, this patient, just a free water restriction, as we mentioned before, increase solute intakes, and the high protein diet also, and the sodium chloride tab, as we mentioned before, 1 to 2 gram per oral TID, urea tab, 10 to 30 gram per oral TID, and stop. Already the patient in hospital will be stop alcohol intake. What is the difference between cerebral salt wasting or renal salt wasting and SIDH? That hypotonic hyponatremia, post-hypotonic hyponatremia. But let's say it's not hypotonic hyponatremia, should be post-hypotonic hyponatremia, yes, and the volume status already low in this, maybe normal or high in SIDH, but the volume here will be low and this will be with also studied. This patient will be hypovolemic, need normal saline here. We need our management by normal saline fluid cortisone, but in SIDH already our management will be water restriction, hypertonic saline loop, diuretic, democycline, and all this means, but only the main management for this is the main management we are using for SIDH. Free water, hypertonic, and this loop diuretics, sodium chloride, and no one use other medication like Vatanzer, this vasopressin receptor antagonist. No one using this, and I didn't see anyone use that. And even this, and all patients doing perfect on this region, and with so many patients like that improved without any other intervention. Just this table already I discussed this before in SIDH and the cerebral salt hosting presentation before. Just what I mean, just the same, this confusing both this diagnosis, but this patient cerebral salt hosting or renal salt hosting, this patient hypovolemic and need more salt and more fluid, and sometimes treated by fludrocortisone to increase the intravascular volume depletion. In comparison by SIDH that need water restriction, and maybe sometimes if severe symptoms, hypertonic saline loop, diuretic, whatever, and sodium chloride tab, urea tab also. Treatment of cerebral salt hosting failure, we have difficulty to differentiate between renal or cerebral salt hosting and SIDH. This is the same terminology. Don't confuse by cerebral salt hosting and renal salt hosting. And SIDH in patient with hyponatremia with brain injury lead to misdiagnosis and mismanagement with fluid restriction. This patient should receive, if the patient cerebral salt hosting, should receive normal saline 0.9, correctly extraarterial blood volume, and hyponatremia. Fludrocortisone 0.1 milligram per oral daily, increase the sodium reabsorption and increase loss of potassium by distal tubules. And chronic hyponatremia, the last message for you, go slow in chronic hyponatremia. Why you are hurried? Don't be hurried to correct chronic hyponatremia rapidly. Please go slow. Go very slow. When I will go very slow, if severe hyponatremia, less than 105, severe hypokalemia, whatever, malnourished, alcoholic, liver cirrhosis, and my patient hypercatabolic state, patient sepsis or septic shock like that. Please go very slow. Don't be hurried to correct the hyponatremia. Don't exceed 8 millimole maximum 8 millimole per liter per day. If high risk patient, 4 to 6 millimole per liter per day. Guideline to treatment, all patients should be on fluid restriction. Careful monitoring urine output, first sign of possible overcorrection of more than 200 ml per hour for 2 hours. Rate of correction 6 millimole per liter over 24 hours if high risk osmotic demyelination syndrome, especially with the theorem sodium less than 120. If low risk of osmotic demyelination, then maximum 8 millimole per day. Don't be hurried to correct rapidly. And 18 millimole over 48 hours, that's okay. The DVB-level patient have suppressed antidiuretic hormone release and had high rate of correction, strict fluid restriction, patient will otherwise get even more hyponatremia. What constitutes overly rapid correction? Any one of this. When I said I am overcorrect my patient, if anyone my ingest more than 10 millimole in the first day, in the first 24 hours, more than 18 millimole in the first 48 hours, more than 8 millimole first 24 hours at any time. At any time, what means maybe after 4 hours, I will found my sodium increase by 8. Maybe after 6 hours, maybe after 12 hours, did before 24 hours. This means your patient will go to overcorrection. When you repeat lab found more than 8, means this patient will go to overcorrection over the next 24 hours. Please take care. This overcorrection alarming sign, especially if a patient with high risk for osmotic demyelination syndrome. And this my reference to rapid review as you like. If you read more, and I hope to listen for all previous presentation before. And I hope you get benefit today and summarize for any, and now you can deal with any hyponatremia, whatever the cause you should, and how you can to approach it to any patient with hyponatremia. ونسألكم دعاء. Don't forget us from دعاء. نسألكم الدعاء بالصحة والعافية والبركة في المال والأهل والأولاد، ولا تنسونا من صالح الدعاء والبركة في الوقت also. ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. والسلام عليكم ورحمة الله وبركاته. وأترككم في رعاية الله وحفظه، ونلقاكم في فيديو قريب بإذن الله. السلام عليكم ورحمة الله وبركاته.